Hello everyone. Today's my discussion is on degeneration and regeneration of nerve fiber. So what is the degeneration and regeneration of nerve fibers? So when the nerve fiber is injured, the destructive and constructive changes that occurs in the nerve fiber that are known as degeneration and regeneration respectively. Now, injury to nerve fiber that occurs in certain conditions like obstruction of the blood flow, local injection of toxic substances, crushing of nerve fibers, transection of nerve fibers, and there are also certain causes of peripheral nerve damage like nerve injury due to trauma and systemic disease such as diabetes and nutritional deficiencies such as vitamin B12 deficiency and infections such as leprosy or AIDS and disruption to blood supply of nerves as occurs with vasculitis and arteriosclerosis and certain side effects of drugs, for instance some anti-cancer drugs. Now, there are two classification systems exist for degree of injury. First is Saddam's classification like neuropraxia, axonotmesis and neurotmesis. Then second is Sunderland's classification, first degree to fifth degree. Sunderland had classified the injury to nerve fibers into 5 categories depending upon the order of severity. Now, first degree injury is transient loss of function that occurs due to mild pressure on the nerve. And the temporary loss of function is mainly caused by local ischemia following obstruction to the blood flow. And nerve fibers completely recover within few hours to few weeks. So this is a first degree, that is neuropraxia. So here is conduction block and that is due to obstruction to blood flow and endoneurium, epineurium and perineurium that are intact. And second degree injury includes nerve damage with intact endoneural tube that occurs due to prolonged pressure on the nerve and the regeneration is delayed but complete as endoneural tube is intact. Third degree injury is the severe damage to the nerve fiber that interrupts the endoneural tube. Then fourth degree injury refers to a severe damage to the nerve associated with disorganization of nerve fasciculi. And fifth degree injury is the complete transection of the nerve and the degenerative changes occurs early. Now it is a Saddam's classification of injury and that is a Sunderland's classification from first degree to fifth degree of injury. Then first degree injury, that is essentially the same as neuropraxia. Now in neuropraxia there is a conduction block and that is the axis cylinder axon with its endoneurium is preserved and there is a physiological conduction block without any anatomic disruption and the injury is temporary and the recovery is complete and recovery period is less than or equal to 3 months and this is seen in a tourniquet palsy and Saturday night palsy and neuropraxia has best prognosis for recovery. Then second degree, that is a axonotmesis and here there is an injury to axon with myelin sheath but endoneurium is preserved and spontaneous recovery is expected in some cases, and this is seen in closed fracture and dislocation. And here the axon not continuous now itself remains intact, and recovery period one each per month. And third degree, now uh, during description of this injury, that is during healing, excessive scarring of the endoneurium occurs that hinders the axon regeneration. In recovery period, less than one each per month, where it is slowed by the scar tissue and determined by the degree of the scarring and involved fascicles. Fourth degree, in which there is a nerve is still in continuity, scar buildup blocks nerve regeneration. And fourth degree, that is a exotmesis and plus endo and perineurium disruption. In third degree, there is a axonotomesis plus endoneurium disruption. Okay, and in recovery period, the surgical intervention required to re-establish the nerve transduction by removing the scar tissue and reconnecting the nerve segments. Then for fifth degree, that is a most severe, and that is known as neurotmesis. And in this injury, there is a rupture of the nerve and it is no longer a continuous fiber. There is a complete transection of the nerve fiber and the recovery requires a surgical intervention. So neuroplexia, that is seen in crutch palsy, tourniquet palsy, Saturday night palsy, and it has the best prognosis for recovery. And axonotmesis is seen in closed fracture and dislocation. To understand this classification, one should know the structure of nerve. The damaged nerve is tested by lightly percussing on its course with a patella hammer from the distal to the proximal end. The tinel sign refers to the tingling sensation that is experienced when the site of the regeneration is reached. As the regenerating axon grows, the site of the tingling sensation also shifts. This is known as advancing tinel sign. So, neuropraxia, tinel sign absent, and axonotmesis, the tinel sign advancing, and type 2 axonotmesis, there is also tinel sign advancing, and in neurotmesis, the tinel sign remains stationary. Okay. Many nerve fibers together form the bundles or fasciculi. Each fasciculus is surrounded by a thicker layer of connective tissue that is known as perineurium. So this is a fasciculus and it is surrounded by a layer that is known as perineurium. Okay, this is a perineurium. And in the peripheral nerves, each nerve fiber is surrounded by a layer of the connective tissue that is known as endoneurium. So here this is a nerve fiber and that is surrounded by a layer and that is known as endoneurium. And the fasciculi that are held together by a layer of the connective tissue that surrounds the entire nerve and that is known as epineurium. So this one is a epineurium. Now this one is a video of classification of nerve injury.
Classification of nerve injury and potential recovery. There are two types of classification. Sunderland classification, 1990. There are 5 grades of nerve injury. Seton classification, 1943. It is classified as neuropraxia, axonotomesis, and neurotomesis. Grade 1 in Sunderland classification corresponds to neuropraxia in the Seton classification. The grade of lesion is mild. Pathology is demyelination. Electrodiagnostic studies show conduction block. Prognosis is excellent up to 3 months. Grade 2 in the Sunderland classification corresponds to axonatomesis in the Seton classification. Grade of lesion is mild to moderate. Pathology is demyelination and axon loss. Electrodiagnostic studies show axon loss. Prognosis is good, limited by time-distance factor. Grade 3 of Sunderland classification corresponds to neurotomesis of the Seton classification. The grade of lesion is moderate. Pathology is grade 2 plus involvement of endoneurium. Electrodiagnostic studies show axon loss, and the prognosis is good to fair. Grade 4 of Sunderland classification corresponds to neurotomesis of the Seton classification. The grade of lesion is severe. The pathology is grade 3 plus involvement of the perineurium. Electrodiagnostic studies show axon loss. Prognosis is poor to nil. Grade 5 of the Sunderland classification corresponds to neurotomesis of the Seton classification, and the grade of lesion is severe. Pathology is grade 4 plus involvement of the epineurium. Electrodiagnostic studies show axon loss, and the prognosis is nil.
Now, degeneration refers to deterioration or impairment or pathological changes of injured tissue. When nerve fiber is injured, various changes that occurs in the nerve cell body and nerve fiber of the same neuron and adjoining neuron. All these changes are together known as degenerative changes. So this is the figure of degenerative changes. Here it is a site of injury, and this part of the axon, that is a distal to the site of injury, and this part of axon or neuron, that is a proximal part to the site of injury. When the changes that take place distal to the site of the injury, that is known as Wallerian degeneration. And now the changes that take place here adjoining neuron, that is transneuronal degeneration anterograde, and this one is a transneuronal degeneration retrograde. Now degenerative changes are classified into three types: Wallerian degeneration, retrograde degeneration, transneuronal degeneration. If an afferent nerve fiber is cut, the degenerative changes occurs in the neuron with which the afferent nerve fiber synapse, that is known as transneuronal degeneration. So this is a transneuronal anterograde degeneration, and this is a transneuronal retrograde degeneration. The series of the degenerative changes are seen at three levels: in the axon distal to injury, in the axon proximal to the injury, and in the cell body. Then Wallerian degeneration. After the nerve is sectioned, the nerve degenerates, and the various functional and morphological changes that occur in the part of the nerve distal to the injury are known as Wallerian degeneration. Though the nerve continues to conduct the impulses for 3 days, after third day, ability to conduct impulses is deteriorated, and after fifth day, the nerve fails to conduct any impulse, and morphological changes start appearing in about 24 hours. Now, which degenerative changes occurs in the distal cut end of the nerve fiber? So first of all, axis cylinder that breaks up into short lengths, and after a few days, little debris means dust-like particles are left in the space formerly occupied by the axon. Myelin sheath breaks up more slowly than the axon into small oily droplets. And its destruction occurs in two stages: physical destruction up to 8 to 10 days, Little or no changes in the histochemistry of oily droplets is seen. Then chemical destruction that starts on the 8th day and goes on till 32nd day. And it is caused by the enzymes of the Schwann cell or macrophages that lining the endoneurial tubes. Principal myelin lipids are free cholesterol, then lipids containing sphingomyelin or cerebrosides and sphingosine. And at the time of the disappearance of the myelin, cholesterol esters appear in large quantities and free cholesterol disappears. Now, if the damage is in the central nervous system, no further changes take place. But if it is in the peripheral nervous system, neurolemma that shows the further changes. Now, the macrophages from the endoneurium that invade the degenerating myelin sheath and axis cylinder. Macrophages that phagocytose the debris formed by the remnants of the myelin sheath and axis cylinder. They also secrete certain enzymes which aid in the destruction of the myelin sheath. So only empty endoneurial tube remain and that is known as ghost tube. Now the degenerating fiber can be stained with Marchis stain and it appears black after staining. While degenerative changes are taking place, the cells of the sheath of the swan divide mitotically and form the rods of the cell lying within the endoneural tube. So, neurilemmal tube is filled with the cytoplasm of the swan cell. This process is completed within the 3 months. At the distal cut end, these growing swan cells differentiate into thin elongated cells which grow in all directions from the cut distal stump at a rate of 1 mm per day. Now what are the changes, degenerative changes that occurs in the nerve cell body? So within 48 hours after the section of the nerve, the Nissl granules, these are the Nissl granules of the nerve cells begin to disintegrate into the fine dust-like particles and that process is known as chromatolysis because the protein synthesis processes are mobilized to help the neuron to survive. So this is a normal cell body of a neuron in which the nucleus is centrally placed and these are the Nissl granules and these are a Golgi apparatus. And after the injury, what are the changes that occurs in the nerve cell body? So here Nissl granules. There is a Nissl substances that appear after the chromatolysis. And nucleus is here centrally placed and that is placed in periphery. And the Golgi apparatus fragments, the cell swells and becomes rounded. The size also increases and becomes cell swells and becomes rounded. Neurofibrils disappear. Nucleus is displaced to the margin of the cell and may be extruded completely, in which case the cell atrophies and dies. In case of the severe injury, death of the cell usually results. If the cell does not die, the repair process begins within 20 days of injury. Nissl granules and Golgi apparatus gradually reappear, cell regains its usual size and nucleus returns to the central position and cell repair may occur even if the axon does not regenerate. Various changes that occurs in the proximal cut end of the nerve fiber or axon like the changes that taking place in the part of the nerve proximal to the site of the injury that are known as retrograde degeneration and changes occurring are the same as Wallerian degeneration but they occur for a variable distance from the site of the injury and they may occur up to the first node of the Ranvier. Okay, so degenerative changes that occurs in the nerve fiber or axon proximal part of from the site of the injury up to the word node of the Ranvier. Now, what is the transneuronal degeneration? Now, if an afferent nerve fiber is cut, the degenerative changes occurs in the neuron with which the afferent nerve fiber synapses. That is known as transneuronal degeneration. For example, chromatolysis in the cells of the lateral geniculate body occurs due to sectioning of the optic nerve. Then degeneration of the cells in the dorsal horn of the spinal cord occurs when the posterior nerve root is cut. Degeneration of the cells in the ventral horn of the spinal cord occurs when there is a tumor in the cerebral cortex. Now in this figure, there is a normal neuron and besides it, there is a degenerating neuron. So first of all, in the normal neuron, this one is a Schwann cell nucleus, this one is a myelin sheath, and this one is a Nissl granules. Now this one is a degenerating neuron and lesion occurs here. So degenerative changes that occurs in the nerve fibers distal to the site of the injury, that is known as Wallerian degeneration, orthograde degeneration or anterograde degeneration. And here you can see very well there is a loss of the axonal structure distal to the lesion and myelin sheath breakdown and degenerates and leaving the debris behind. And microglia or macrophages scavenges the debris breakdown and these all are macrophages. Then degenerative changes that occurs proximal to the site of the lesion, that is known as retrograde degeneration. And here you can see very well there is a Nissl granules disintegrates or fragmented and that process is known as chromatolysis. Now the transneuronal degeneration. Transneuronal degeneration that occurs in adjoining neuron. So here the retrograde neurons terminal retract and neuron degenerates. And this one is a anterograde transneuronal degeneration. The anterograde neuron degenerates. The injured and degenerated nerve fiber can regenerate and it starts as early as 4th day after the injury but becomes more effective only after 30 days and it is completed in about 80 days. If the neuron survives, the nerve fiber regenerates as follows. First, some pseudopodia-like extension grow from the proximal cut end here. So this extension are known as fibrils or regenerative sprouts. The number of the fibril is up to 100. Fibrils move towards the distal cut end of the nerve fiber. Some of the fibrils enter the neurilemmal tube of the distal end form the axis cylinder. Schwann cells line up in the neurilemmal tube and actually guide the fibrils into the tube. Schwann cells also synthesize nerve growth factor which attract the fibrils from the proximal segment. Then axis cylinder is fully established inside the neurilemmal tube and these processes are completed in about 3 months after the injury. Myelin sheath is formed by Schwann cells slowly and myelination is completed in 1 year. Diameter of the nerve fiber gradually increases. However, the degenerated nerve fiber obtains only 80% of the original diameter. The newly formed internodes are also shorter than the original ones. In the nerve cell body, the Nissl granules appear followed by Golgi apparatus. Cell loses the excess fluid and nucleus occupies the central portion. Though the anatomical regeneration occurs in the nerve, Functional recovery occurs after a long period. Then what are the criteria for the regeneration? Regeneration is possible only if certain criteria are fulfilled by the degenerated nerve fiber. Gap between the cut end of the nerve should not exceed 3 mm. And neurilemma must be present. As neurilemma is absent in the central nervous system, the regeneration of the nerve does not occur in the central nervous system. Then nucleus must be intact. If it is extruded from the nerve cell body, the nerve is atrophied and the regeneration does not occur. And two cut ends should remain in the same line. Regeneration does not occur if any one end is moved away. Then what are the complications following the nerve injury? So complete atrophy of the nerve fiber occurs in severe injuries where regeneration does not occur due to absence of the favorable circumstances. Then functional complication in the form of the misinterpretation of the sensation occurs when the fibrils do not enter the appropriate tubes and thus there are faulty connections. Then neuroma. Neuroma formation occurs if during regeneration nerve fibrils growing from the proximal cut end of the axon do not find their way if the gap between two cut ends is too large. Under such circumstances, the fibril turn round in search of the endoneural tube in a hole-like mass known as neuroma and which may be quite painful. Now, what is the phantom limb? Phantom limb is a feeling sometimes perceived by patients following the amputation of the limb. Neuroma that is developed at the site of the amputation when excited that causes the patient to feel like the lost limb is still present. So, a feeling of phantom limb. Now, in my next slide, there is a video of regeneration of nerve fiber. So, please see that video.
Regeneration of nerve fiber. In this topic, we are going to be dealing with the criteria for regeneration and the stages of regeneration. The term regeneration refers to regrowth of lost or destroyed part of a tissue. The injured and degenerated nerve fiber can regenerate. It starts as early as 4th day after injury, but becomes more effective only after 30 days and is completed in about 80 days. Criteria for regeneration. Regeneration is possible only if certain criteria are fulfilled by the degenerated nerve fiber. The criteria are as follows. Gap between the cut ends of the nerve should not exceed 3 millimeters. Neurolemma should be present. As neurolemma is absent in CNS, the regeneration of nerve does not occur in the CNS. Nucleus must be intact. If it is extruded from the nerve cell body, the nerve is atrophied and the regeneration does not occur. Two cut ends should remain in the same line. Regeneration does not occur if any one end is moved away. Stages of regeneration. First, some pseudopodia-like extensions grow from the proximal cut end of the nerve. These extensions are called fibrils or regenerative sprouts. The number of fibrils is up to 100. Fibrils move towards the distal cut end of the nerve fiber. Some of the fibrils enter the neurolemma tube of distal end and form axis cylinder. Some of the fibrils enter the neurolemmal tube of distal end and form axis cylinder. Schwann cells line up in the neurolemmal tube and actually guide the fibrils into the tube. Schwann cells also synthesize nerve growth factors which attract the fibrils from proximal segment. Axis cylinder is fully established inside the neurolemmal tube. These processes are completed in about 3 months after injury. Myelin sheath is formed by Schwann cells slowly. Myelination is completed in 1 year. Diameter of the nerve fiber gradually increases. However, the degenerated nerve fiber obtains only 80% of original diameter. Newly formed internodes are also shorter than the original ones. In the nerve cell body, first the Nissl granules appear, followed by Golgi apparatus. Cell loses the excess fluid. The nucleus occupies the central portion. Though anatomical regeneration occurs in the nerve, functional recovery occurs after a long period.
Thank you very much.